So good morning, everybody. I am Salvatore. I'm an assistant professor of medicine and transplant hepatologist at the University Hospital of Padova. And I will co-chair this session with Sonia Balboni from PPTA. I'm happy to welcome you to this session about novel perspectives on albumin use in patients with cirrhosis. You know that albumin has several established indications for complications of cirrhosis, such as tense ascites, hepatorenal syndrome, and spontaneous bacterial peritonitis. But in recent years, we had new data supporting new indications for albumin use. And during this session, we'll have 3 talks about the use of albumin for the treatment of hepatic encephalopathy, the long-term use in patients with ascites as a disease-modifying agent, and in acute and chronic liver failure. And the last talk will introduce a new initiative from PPTA that is a digital educational platform about albumin use in patients with cirrhosis. Therefore, I'm pleased to invite the first speaker, that is Paolo Caraceni from the University of Bologna. Please, Paolo.
Thank you, Salvatore, Sonia. Good morning, everybody. Thanks for the invitation. It's really a pleasure to be here in Lisbon at the International Protein Plasma Congress. Okay, this is the agenda of my talk, and to start the session on cirrhosis and albumin, I would like to share with you a few information about the clinical and socio-economic burden of cirrhosis. Well, the natural history of chronic liver disease is quite similar, regardless the underlying etiology. Alcohol, viruses, and metabolic syndrome are currently the most prevalent etiologies of cirrhosis. Some of the patients with chronic inflammation of the liver, with chronic hepatitis, over decades will develop cirrhosis. Cirrhosis is classically divided in 2 phases, the compensated cirrhosis and the decompensated cirrhosis. Compensated cirrhosis is usually asymptomatic, while decompensated cirrhosis is characterized by the recurrent occurrence of severe and life-threatening complications such as jaundice, hepatic encephalopathy, ascites, which is the accumulation of fluid in the belly, bacterial infection, gastrointestinal bleedings, and hepatocellular carcinoma. The transition to decompensation occurs in 5% of compensated patients every year and marks a dramatic drop in life expectancies from more than 12 years in the compensated phases to only 2 to 4 years in the decompensated phase. Well, cirrhosis is relatively frequent around the world, with important differences between the different geographical areas. Well, it has been estimated that more than 10 million of individuals suffer of decompensated cirrhosis around the world. More than 1 million of these individuals die every year for decompensated cirrhosis, and of them, 170,000 only in Europe. But even more important, the cirrhosis is a leading cause of death in the adult population between 40 and 65 years old. So it's not surprising that the number of years of working life lost by these patients due to disability is extremely high. Another reason that makes the economic burden of cirrhosis very heavy is the high rate of hospitalizations of these patients due to recurrent clinical complications. Just to give you an idea, once discharged from the hospital, these patients present a 30% possibility to be readmitted within 1 month and up to 50% within 6 months. Well, just to summarize this part, I would say that liver cirrhosis is a leading cause of death worldwide, About two-thirds of mortality of cirrhosis occurs in individuals below the age of 65 years. A large proportion of the years lost due to disability from cirrhosis are years of work life. And finally, the healthcare costs related to cirrhosis are heavy due to the high rate of hospitalizations, long hospital stays, and frequent readmissions. Well, let's move now to the main topic of my talk, that is hepatic encephalopathy, a major complication of cirrhosis. Hepatic encephalopathy can be defined as a brain dysfunction caused by liver failure and or portal systemic blood shunting related to portal hypertension that produces a spectrum of neurological or psychiatric abnormalities ranging from subclinical alterations to coma. Well, hepatic encephalopathy can be subclinical without symptoms and diagnosed only by psychometric tests, but even this covert subclinical form can have an impact on these patients because they present, for example, a driving inability, and the incidence of car accidents in this population is higher as compared to the normal individuals. When symptoms are present, they are usually classified using the West Evans scale, and the disease can be divided in 4 stages from 1 to 4. The clinical symptoms ranges from lack of awareness, euphoria, anxiety, shortened attention, difficult to perform calculation, to lethargy, apathy, or disorientation for time or place, personality change, inappropriate behavior, then to somnolence, stupor, confusion, gross disorientation. Sometimes these patients become very, very aggressive and very difficult to deal with them for families and caregivers, until coma. It can be a deep coma, but since it's a metabolic coma, this patient usually can recover from this coma. But you can imagine how difficult, how dramatic is the impact of hepatic encephalopathy on these patients and also on caregivers and families. Well, just to give some numbers, the prevalence of hepatic encephalopathy in patients with cirrhosis ranges from 20 to 80% and increases with the progression of the severity of the disease. Up to 25% of patients suffer an episode of hepatic encephalopathy within 5 years from the initial diagnosis of cirrhosis. And after the first episode, they have a 40% probability to have a new episode, at least a new episode in the following year. Also, we have to consider that the incidence of hepatic encephalopathy has been increasing for the last years because of many factors, including increasing aging, increasing alcohol consumption, increasing comorbidities like obesity, diabetes, renal failure, and others. So, severe hepatic encephalopathy is also associated with the worse of survival, and up to 80% of patients with cirrhosis require hospitalization due to hepatic encephalopathy in a 5-year follow-up, and once are discharged, they have a 50% of possibilities to be readmitted for hepatic encephalopathy within a month. So hepatic encephalopathy drives to disability in many cases, also due to the recurrent falls. It's a cause of a very high direct cost due to the hospitalization, but it's also a cause of a very high indirect cost, since these patients require a very continuous assistance by caregivers and families with the absence of work and loss of wages. So there is really a need to prevent the episode of hepatic encephalopathy. Now, which is the pathophysiological rationale of using albumin against hepatic encephalopathy? Well, the usual pathogenesis resides on the reduced detoxification by the liver of ammonia and other toxins produced by the intestine due to the reduced catabolic capacity of the cirrhotic liver and the presence of portal systemic shunting. As a result, high levels of ammonia and other toxins reach the systemic circulation and cross the blood-brain barriers disrupting the normal communication between the different brain cells. That's why the current treatments are aimed to reduce the production of ammonia in the gut. So we use laxative, mostly non-absorbable disaccharides, to cleanse the intestine, and also we use rifaximin, which is a poorly absorbable antibiotic, which reduces the amount of bacteria producing ammonia. However, in the last decade, it has become clear that the pathogenesis of hepatic encephalopathy is much more complex. I will not go into details, but just to say that besides hyperammonemia, the systemic inflammation and the oxidative stress which characterize decompensated cirrhosis are driving factors also for hepatic encephalopathy. And this is why albumin can help. Indeed, we know that albumin is the main regulator of fluid distribution among the different body compartments due to its oncotic properties, but albumin is also provided of many other biological functions which are unrelated to oncotic properties. It binds, transports, and detoxifies many endogenous and exogenous compounds, is the major circulating antioxidant in our body. It stabilizes endothelia, and also it modulates the inflammatory and the immunological response. So that's why, for its anti-inflammatory and antioxidant capacity, albumin has been proposed among the emerging pharmacological approaches against hepatic encephalopathy. Well, which are the clinical evidence supporting the use of albumin against hepatic encephalopathy? Not many, they are still controversial, but we have evidence. Well, the first randomized clinical trial was published about 10 years ago by a Spanish group. This was a randomized clinical trial in patients hospitalized for an episode of acute hepatic encephalopathy, at least of grade 2. And these patients were randomized to receive albumin or saline. And albumin was given with the dose which was proved to be effective against another complication of cirrhosis, which is spontaneous bacterial peritonitis. So 1.5 grams per kilo body weight at diagnosis and 1 gram per kilo body weight at day 3. Unfortunately, the results of these studies were disappointing because there were no differences between the two groups regarding the clinical resolution of hepatic encephalopathy at day 5, which was the primary endpoint of the study, nor there were differences among the scale who allowed the classification of hepatic encephalopathy, because, as you can see, the changes were similar in the two groups. A second randomized clinical trial was published a few years later, always by a Spanish group, same type of patients, same schedule of administration, and again, no differences were seen regarding the transplant-free survival at 90 days and the cumulative incidence of death at 90 days, which were main endpoint of the study. However, in the same study, the authors pulled together the two populations of the two trials to increase the sample size, and in this way, they were able to see a difference in favor of albumin, either for the transplant-free survival and the cumulative incidence of death. Of course, it's a post-hoc analysis, and so there is a promising result, but it's not very solid. However, things change if albumin is given for a prolonged or a long time, because in this case, you will see that we have evidence of benefit. The EAL study was published a few months ago, is a double-blind, randomized, placebo-controlled trial of albumin in patients with hepatic encephalopathy. It was done in the United States. people with patients with cirrhosis and a prior episode of hepatic encephalopathy who have still cognitive impairment or minimal hepatic encephalopathy despite standard of care were randomized to receive albumin or saline for 5 weeks. They were randomized 1-to-1, and the dose of albumin was 1.5 grams per kilo weekly for 5 weeks. And then patients were also followed for 1 week after the termination of treatment. In this case, you will see a benefit of albumin because patients receiving albumin more frequently resolved minimal hepatic encephalopathy, improving their neuropsychometric tests, but also these positive results was associated with a better psychosocial quality of life and a reduction of the endothelial dysfunction and inflammation. And the positive results also remained evident 1 week after the end of treatment. Positive results were also seen when albumin was given long-term. This is the ANSWER trial, which was not designed specifically to assess hepatic encephalopathy, but hepatic encephalopathy was one of the secondary endpoints. The ANSWER trial is a no-profit, open-label, randomized clinical trial performed in 31 centers in Italy, enrolling 431 patients with cirrhosis and uncomplicated ascites. Patients receive standard medical treatment or standard medical treatment plus 40 grams of albumin twice a week for the initial 2 weeks as a sort of loading dose, and then 40 grams a week up to a maximum of 18 months. In this case, you can see that the incidence of new episodes of grade 3 and 4 hepatic encephalopathy were significantly reduced in the group receiving albumin in the 18 months from 36% to 23%, and the difference started to be evident after 2 months of treatment. And when we consider the entire number of episodes of hepatic encephalopathy, as for many other complications of cirrhosis, albumin treatment was associated with the significant reduction of the incidence rate. A reduction that was close to 50%, so very good results. In conclusion, acute administration of albumin does not appear to be effective for treatment of overt episodes of hepatic encephalopathy. In contrast, accumulating evidence indicates the benefit of prolonged and regular albumin administration in improving neuropsychological tests and, more important, in preventing overt episodes of hepatic encephalopathy. Of course, additional well-designed studies focused on hepatic encephalopathy are needed to confirm these positive findings and to understand the potential mechanism of the albumin effects on hepatic encephalopathy. Thank you very much for the attention.
When you're done with your talk, turn it back to me.
Thank you very much, Paolo. We will have the discussion at the end. So can I have my slides, please? So I will talk about the long-term use of albumin in patients with cirrhosis. Paolo has already shown you the results of the ANSWER trial, and he has also talked about oncodic and non-oncodic properties of albumin that may be key for preventing complications of cirrhosis. Indeed, if we look at the current hypothesis, unified hypothesis about the development of complications of cirrhosis, where systemic inflammation is key, you can see that albumin, toward its non-oncodic properties, may counteract systemic inflammation. Toward oncodic properties, it may counteract the reduction of effective circulating volume due to the splanchnic arterial vasodilation. And both oncodic and non-oncodic properties contribute to counteract the cardiocirculatory dysfunction. We have established an indication for the prevention for albumin in the prevention of post-paracentesis circulatory dysfunction, in the prevention of acute kidney injury in patients with spontaneous bacterial peritonitis and in the treatment of hepatorenal syndrome. But in recent years, we have also strong data about the long-term use of albumin as a disease-modifying treatment in patients with cirrhosis and ascites. The first trial investigating the use of long-term albumin in patients with cirrhosis and ascites was a single-center, open-label, randomized controlled trial performed in Florence, where patients were randomized to receive albumin at the dose of 25 grams per week for 12 months and 25 grams every 2 weeks thereafter. And as you can see, patients randomized to receive albumin had a significantly higher probability of survival than those randomized to standard medical treatment. However, this was a small study, just 100 patients, and was not powered enough to see a difference in terms of survival. Thereafter, the Answer trial, which was an investigator-initiated, pragmatic, open-label, randomized controlled trial, randomized patients with cirrhosis and non-complicated ascites requiring anti-aldosteronic drug at the dose of at least 200 milligrams per day and furosemide at the dose of at least 25 milligrams per day to receive standard medical treatment or standard medical treatment plus albumin at the dose of 40 grams twice a week for the first 2 weeks and 40 grams a week thereafter for 18 months. And the primary endpoint of the study was survival. Albumin was administered mainly in outpatient clinic, but even in out-of-hospital outpatient clinic or at-home care assistance. 4 vials were administered in about 3 to 60 minutes. Here you can see the main results of the study, showing that patients randomized to receive human albumin had a significantly higher probability of survival than those randomized to receive standard medical treatment, and even adjusting for confounders such as age, the etiology of liver disease, and scores of liver disease such as the Child-Pugh score and the MELD sodium score, patients randomized to receive human albumin has a 44% reduction in the risk of death. And the reduction of death was mainly due to a reduction on liver-related death, while non-liver-related death did not change, suggesting that the effects of albumin were specific for complication of cirrhosis. The administration of human albumin also improved the control of ascites. You can see on your left side that patients that were randomized to receive human albumin had a significantly lower incidence of paracentesis than those randomized to receive standard medical treatment, and also the cumulative incidence of refractory ascites was significantly reduced in patients randomized to receive human albumin. Paolo already showed you these slides. Human albumin in the Answer trial reduced the incidence of most of the complications of cirrhosis, including spontaneous bacterial peritonitis, non-SBP infections, hepatic encephalopathy of grade 3 or 4, acute kidney injury, hepatorenal syndrome type 1, and dilutional hyponatremia, without increasing the risk of gastroesophageal bleeding. Moreover, patients randomized to receive human albumin had a significant reduction in the incidence rate ratio of all-cause hospitalization, and this was mainly due to a reduction of hospitalization caused by complication of cirrhosis, here referred to as liver-related hospitalization. And at the end of the study, the incidence rate ratio of days in hospital was significantly reduced in the human albumin group. In our institution, we performed another study that was a non-randomized open-label study where we compared the probability of survival in patients with refractory ascites receiving albumin at the dose of 20 grams twice a week versus standard treatment. And as you can see, patients receiving albumin had a significantly lower incidence of death than those receiving standard medical treatment alone. Moreover, similar to the Answer trial, we also showed a reduced incidence of hepatic encephalopathy, spontaneous bacterial peritonitis, non-SBP infections causing hospitalization in these patients. During the recent years, there was another important study evaluating the use of albumin in patients with decompensated cirrhosis. This is the MATCH trial, where patients with cirrhosis and ascites or liver transplant waiting list were randomized to receive albumin at a dose of 40 grams every 15 days, or plasmidodrine, or matched placebo. And as you can see, there was no difference between the two groups in terms of complication of cirrhosis, which was the primary endpoint of the study. However, to understand this difference, we should realize that these trials were quite different in the population. All patients with ascites requiring high dose of diuretics in the Answer trial, which has more than double of the patients of the MATCH trial, while in the MATCH trial, patients were on the transplant waiting list. The MATCH trial has a comparator placebo and was double-blind. And one of the criticisms to the Answer trial is that these patients were receiving albumin and therefore had more contact with the healthcare. However, this does not explain some of the complications that we have seen, because we know that infections increase when the patients have more contact with healthcare, while in the Answer trial, there was a reduced incidence of infection in patients randomized to receive albumin. Therefore, we need to understand better this difference, and one key is the duration of treatment. As you can see, in the Answer trial, patients were treated with albumin for a median of 14 months, while in the MATCH trial, patients were treated for a median of 60 days because the transplant program is quite effective in Spain, and therefore they were transplanted soon after randomization. And you know, this is very important because if we look at the survival curve in the Answer trial, you can see that the curve starts separating after 2 months of treatment. Therefore, it is likely that in the MATCH trial, patients were not treated for enough time to see a difference between the two groups. There is another key difference between these two trials, that is the albumin dose, that was quite higher in the Answer trial than in the MATCH trial. And moreover, the treatment in the Answer trial was able to increase significantly albumin concentration, while no difference were observed in the MATCH trial. You can see in this slide, on your left side, albumin concentration during treatment in the Answer trial, and on the right side, the albumin concentration in the MATCH trial. In the Answer trial, after 1 month, there was a significant increase in albumin that was maintained during treatment, no difference in the MATCH trial. And this is quite important because if we want to see the non-oncotic properties of albumin and the anti-inflammatory effect of albumin, the patients should have an increase of human albumin concentration. And we understood that from the Preziosa pilot trial. This was a study where investigators were looking for a concentration of albumin, a dose of albumin able to normalize concentration of human albumin in patients with cirrhosis to be explored in a phase 3 randomized controlled trial. They started with a lower dose, 1 gram per kilogram every 2 weeks, that was not able to restore human albumin concentration in many patients. Therefore, they moved to a higher dose, 1.5 gram per kilogram every week. And as you can see, this dose on your left side was able to normalize the concentration in all patients. But what is very interesting on your right side, that the high dose of the patient receiving high dose of albumin had a significant reduction in interleukin-6, that is a biomarker of systemic inflammation that has key role in patients with cirrhosis. Moreover, in the Answer trial, when we observed the concentration of human albumin after the first months of treatment and the association between the concentration and 18 months probability of survival, you can see that higher the dose of albumin, higher the probability of survival, and the best results were observed when human albumin concentration was above 4 grams per deciliter. And this allowed to hypothesize that probably treatment may be personalized, because in that study we showed that predictors of lack of reaching this threshold of 4 grams per dl were the baseline serum albumin concentration and the severity of liver disease evaluated by MELD score. Therefore, if we want to fill the gap of albumin, we can probably adapt and personalize the treatment, and this should be explored in the future. If we want to apply the long-term use of albumin to patients with cirrhosis and ascites, we need to overcome some main barriers. Some are costs and other are logistics. I will not discuss in detail about logistics. I will talk about cost, because in the Answer trial, a cost-effectiveness analysis was performed considering direct costs due to liver-related hospitalization, paracentesis, albumin infused for the evidence-based indication, albumin infused per protocol, and accesses to the hospital to receive the infusion of albumin. And at the end, patients randomized to receive human albumin had a yearly increase in cost of 2,500 euros, and the incremental cost-effectiveness ratio for any quality-adjusted life years was 24,000 euro. And if we put at 35,000 euro the willingness to pay, and we perform a bootstrap analysis of simulation about albumin use, in 92% of cases, the human albumin is cost-effective. And what is more interesting is that in 56% of bootstrap simulation, human albumin was even cost-saving. So in conclusion, ladies and gentlemen, long-term use of albumin in patients with cirrhosis and ascites is able to reduce the occurrence of further decompensation and improve survival. However, to be effective, the treatment should be given for at least 2 months and should be able to increase the baseline levels of albumin. Long-term albumin infusion may be cost-effective. However, further analysis should be done according to each healthcare system in different countries and healthcare models. Finally, long-term human albumin infusion requires to set up the logistic, but it can be feasible and should not be necessarily occur in the liver unit. Thank you very much for your attention. Now I'm very pleased to introduce Dr. Rakhi Maiwall, that is professor of hepatology and head on the liver intensive care unit at the Institute of Liver of Biliary Sciences in New Delhi, and she is definitely an expert about acute and chronic liver failure. Please, Rakhi.
Thank you, Salvatore, for that kind introduction. And I would like to thank the organizers for this lovely invitation, visiting this lovely city, and also giving me an opportunity to talk about the use of albumin in patients with acute and chronic liver failure. So this is going to be the outline of my talk. I'll talk about the concept and definition of acute and chronic liver failure, the structure, biology, and functions of albumin in these patients, the modifications that happen in patients with acute and chronic liver failure, and then go on to the uses of albumin and the mechanism. So this is the apostle concept of acute and chronic liver failure, to show here that you have a patient of ACLF who has a chronic injury, which is a chronic liver disease. This is usually asymptomatic. Most of these patients are compensated, and they had never presented to us prior with the decompensated related event. So decompensated patients with cirrhosis are excluded out. These patients for the first time present with an acute insult, which could be in the form of alcohol, viral, drugs, autoimmune liver diseases, and then this leads to the development of liver failure. So the liver failure component should have jaundice and coagulopathy, which is complicated with ascites and or encephalopathy that develops very quickly within a matter of 4 weeks in these patients. And why these patients are different is because as compared to patients with decompensated liver cirrhosis, these patients are distinct in the development of the extrahepatic organ failures, the development of infections, leading to a very high short-term mortality. And the other unique thing about this syndrome is about the reversibility. So you can reverse the syndrome with aggressive measures, and that's why this becomes very important to identify for listing these patients for a timely liver transplant, but also achieving a reversibility. But we should also look at the other definition, very important, which is followed in Europe and across various centers, is the Easel-Cliff definition. Now, the Easel-Cliff definition is more unanimous in including decompensated patients with cirrhosis, and they define acute and chronic liver failure as an acute deterioration of a pre-existing chronic liver disease, which is related to a precipitating event and associated with increased mortality due to multi-system organ failures. But whatever way you define acute and chronic liver failure, you see here the mortality varies from 34% as reported by the Easel-Cliff Consortium at 20 days to around 51% if you use the APASL definition. So it's very important that we manage these patients. Now let's look at the pathogenetic basis of what happens in acute and chronic liver failure, why these patients are going to rapid development of organ failures. And it has been clearly seen that it is a systemic inflammation, which is a driver of organ involvement in patients with acute and chronic liver failure. So these patients have gut dysbiosis, bacterial infections and translocation, and circulating pathogen-associated molecular pattern. And the dying and dead necrotic hepatocytes release the damage-associated molecular pattern, which is there in the circulation. And these circulating DAMs and PAMs, they activate the pathogen recognition receptors on the innate immune cells, causing a release of the systemic pro-inflammatory cytokine response, which is responsible for the organ damage or the organ pathology. This also results in mitochondrial dysfunction. There is peripheral decrease in the oxidative phosphorylation and ATP production, and also a very severe circulatory dysfunction, which is mediated by severe splanchnic vasodilatation, overactivation of the endogenous neurohumoral system, and intense vasoconstriction. And this is particularly responsible for the development of AKI, which is the most frequent extrahepatic organ failure that develops in these patients. Now, this is an interesting data looking at the blood metabolomics in patients with acute and chronic liver failure. So this was, the cohort included was patients with acute and chronic liver failure, 181 patients who were compared with patients with acute decompensation of cirrhosis, 650, then compared to compensated cirrhosis and healthy controls. And the interesting part of this was found that patients with ACLF, when you look at the blood metabolomics in these patients, you find that there is a distinctive ACLF fingerprint which correlated with the intensity of systemic inflammation and represented increase in the glycolysis and related pathways. And together, this fingerprint showed a defective mitochondrial ATP beta fatty acid beta oxidation, which was responsible for the development of organ failure. So all this is very important. And this is something from our own group where we looked at patients with acute and chronic liver failure. And you can see here, all these patients had ACLF. Just to show here, we looked at the mitochondrial function in the monocytes, and patients with ACLF were compared without SIRS or sepsis to patients who had just systemic inflammation and patients who had infections. And we can see here, with the development of sepsis, there is a further marked decrease in the mitochondrial function. And that's why we say infections are a sinister sign associated with worse prognosis. We can see here the basal respiration of the mitochondria, the maximal respiration, and the ATP production was markedly suppressed in patients of ACLF who had infections. So why are we discussing about the role of albumin in these patients? And this has been discussed by my distinguished speakers about the oncotic and non-oncotic functions. So when we see pathogenetic basis of patients with acute and chronic liver failure, we want the albumin to not only improve the severe circulatory dysfunction, but all the other properties we would like to explore of how it can counteract the systemic inflammation and the oxidative stress which is there in these patients. Now, what happens to the albumin in these patients is also very interesting. So for that, you need to understand that in the healthy population, there are 3 isoforms of albumin, okay? So this is the human mercaptoalbumin, which is the reduced form, and this is what is the functional albumin. And majority will be in 70 to 80%, this albumin is existent. However, the albumin undergoes reversible and irreversible oxidation, and we can see here that the HNA2 fraction, which is irreversibly oxidized albumin, this becomes the dysfunctional albumin. It loses its properties of improving the endothelial barrier function and immunomodulation. And similarly, HNA1 is a reversibly oxidized fraction. So in patients with acute and chronic liver failure, because of the marked loss of the hepatocyte mass, so it is not only the quantity of albumin that gets reduced, it is also the albumin becomes dysfunctional. And I'll show you the data supporting this finding. So this is the data again from the Easel-Cliff Consortium, where they showed that in patients with acute and chronic liver failure, when they looked at the plasma renin capacity, the pro-inflammatory cytokines, IL-6 and IL-8, and the isoforms of albumin. So you can see here when they stratified these patients based on whether they died at 28 days versus who survived, they found that the HNA2 fraction of albumin in survivors was lower as compared to non-survivors, and this remained consistently higher in the non-survivors dynamically on dynamic assessment. So this is something which is responsible for poor prognosis in these patients. And when we looked at our own data, and this is data from our group where we looked at patients with severe alcoholic hepatitis, most of these patients had ACLF, and compared them to patients with alcohol-related decompensated cirrhosis and healthy controls. And over here, we looked at all the albumin isoforms, and we found that in patients with the severe alcohol hepatitis patients, we can see here the HMA was reduced and the HNA2 fraction was markedly increased, and so was the ratio. So most of the albumin in these patients was dysfunctional. And what this dysfunctional albumin further did was, we further went on in a series of experiments to show that this dysfunctional or HNA2 fraction of albumin was causing activation of the neutrophils. And these neutrophils had an increased release of the NGAL, the myeloperoxidase, and the cytokines, and further perpetuated the oxidative stress. So it's a vicious cycle that the albumin becomes dysfunctional, and this dysfunctional albumin causes dysfunctional innate immune system. And in subsequent work, we showed that this dysfunctional albumin in severe alcoholic hepatitis patients, again, just to show here, we did the proteomics of the platelets, and we demonstrated that there was the activation of inflammation-related genes and in these platelets of severe alcoholic hepatitis, which gave them a pro-inflammatory phenotype. And there was a downregulation of the genes related to coagulation, which gave them a prothrombotic phenotype. And this was mediated by, again, HNA2 fraction of this albumin. And this was acting in these platelets by conferring this activated phenotype through the CD36 receptor on the platelet membranes. So this is just to show you how this HNA2 fraction in patients with ACLF is increased and how it becomes dysfunctional, and this dysfunctional albumin drives activation of the platelets and neutrophils. So how do we use albumin in patients with ACLF? And this is, again, some work from our group. This is a randomized control trial, just to show here that patients with ACLF have severe circulatory dysfunction. And they develop paracentesis-induced circulatory dysfunction even if you do a modest volume paracentesis. So if you see here in this particular trial, we showed that if you're tapping less than 5 liters, which is not the current recommendation to replace, but if you're doing this in an ACLF patient, you see here, the incidence of paracentesis-induced circulatory dysfunction is 70%, and then we can bring down this to 30% with the use of albumin, even with a modest volume paracentesis. And this development of PICD was identified as an independent predictor of poor outcomes in these patients. This is another interesting trial which we completed in our center, the Asia trial. And here we were exploring the benefits of long-term albumin usage in patients with acute on chronic liver failure. So we talked about the ANSWER study in uncomplicated ascites. This set of patients included patients with ACLF. And what the dose of albumin we designed was we gave them 40 grams on day 1, followed by 20 grams every day for the first 7 days, and then every alternate day till day 28 in the albumin protocol group, and the other group received the standard medical treatment. And we followed up these patients, and for the development of complications, we found that the mortality was significantly reduced with the use of albumin, and so was the reduction in the incidence of new development of infections, improvement in the systemic inflammatory response score, and also a reduction in the ACLF liver severity score, that is the ARC score. Now, this is another very interesting study which has just come up in JHEP by Professor Jalan's group, and why I wanted to show this paper. This is a phase 2 study on patients with acute and chronic liver failure, where they were exploring the benefits of a dialysis liver, the Dialiv liver dialysis machine. And this liver dialysis device has a renal dialysis, and it has 2 membranes in series. The first membrane will absorb the dysfunctional albumin and the cytokines, and the second, the PAMs and the DAMP molecules. And I told you about how these are important, and this is replaced by an exogenous albumin. So very interesting results here to show that how you use this Dialiv machine. And we can see here that all the HMA fraction in the Dialiv-treated group versus the standard of care group, the HNA2 fraction showed reduction, and so was an improvement in the functionality of albumin, as was seen by the binding efficiency, the ischemia-modified albumin ratio, and the detoxification efficiency. I'm not going into the details because of the lack of time, but this is how the Dialiv was able to improve the dysfunctional albumin in these patients. And then the last part of my talk was about ACLF. What dose of albumin should we be using? So we know the benefits of the albumin usage, and we heard about high dosages of albumin, and this is a Preciosa study which showed that a higher dose was better in combating the systemic inflammation and counteracting the circulatory dysfunction. But again, we need to be very careful in the context of ACLF patients who are hospitalized with infections, because these patients have capillary leak, they have high hydrostatic pressure, they're already hypoalbuminemic, and they have an increased transcapillary albumin passage. So this is further increased by the low recirculation of albumin, the defective lymphatics in these patients, and increase of albumin in the extravascular compartment. So if you give a higher dose at a rapid speed, this may result in hypovolemia and may further worsen the tissue hypoxia. And this is what we found in this ALPS randomized control trial of using 20% albumin as a volume resuscitation in patients who had sepsis-induced hypertension. All these patients were in the intensive care unit. They were very sick patients with infections. And when we compared this 20% albumin to plasma light, we found that albumin was a better volume expander and was able to achieve the macrocirculation and microcirculatory improvement. But at the cost of most severe adverse events, we can see here in the blue lines how the increase in the CVP, the IVC diameter, and the decline in the PF ratio was seen in patients who were given albumin as compared to the plasma light. Even though the volume of fluid given was less, but the amount of and the incidence of pulmonary complication was seen in 1 in 5 patients, so 20% required discontinuation, and this was more marked, and we found that patients who had pneumonia, patients who had higher arterial lactate and SOFA scores were the ones who developed these adverse events with the albumin infusion. So I would like to summarize my talk by saying that systemic inflammation is a driver of organ failures in patients with ACLF. There is some data to suggest the albumin can restore the altered immune homeostasis in these patients. We have level 1 evidence showing that albumin decreases the incidence of circulatory dysfunction and the associated with paracentesis in these patients. The dialev looks very promising in improving the dysfunctional albumin, and the risk of cardiopulmonary complications with albumin and ACLF merits immense caution. Thank you.
Thank you very much, Rakhi. Now we move to the last talk. I'm pleased to invite Giacomo Zaccherini from the University of Bologna to introduce the Albumin Learning Network, this new digital educational platform from Plasma Protein Therapeutic Association. So please, Giacomo.
Thank you, Salvatore. Thank you, Sonia. Good morning to everybody. It is a great pleasure for me to be here in this Congress, and I am very proud to introduce you to the Albumin Learning Network, this new initiative from PPTA that has the demanding challenge to provide healthcare professionals and researchers literally what they need to know about albumin and its uses. Well, the outline of my presentation will be to go through we can say, the 5 W's of the Albumin Learning Network: the why, the what, the how, the who, and the when. Let's start with the fundamental question, the why. What is the open question, the unmet need that we decided to address? Do we really need an educational tool specifically dedicated to albumin and its clinical uses? Well, we can see from market reports, these are publicly accessible data, but I know that you all have your own data, that albumin use is rapidly increasing worldwide. And we also have just seen from the previous presentation that also indications for albumin uses are changing over time, are updating. So it is important to balance the increased use worldwide with an increased, with a stronger scientific awareness and a deeper knowledge of albumin function and albumin mechanism in clinical. So the what we decided to provide. The Albumin Learning Network would like to be many things at the same time. First of all, a collection of learning contents and materials, but also a venue for online educational events, and also a peer network for physicians and researchers to get in touch and to discuss and to grow together in the knowledge of albumin use. So the first step is to provide a collection of learning contents on the albumin molecule, its biochemical properties, and its clinical uses. So we have done educational videos with voiceover on many topics on albumin use, from the biochemical properties until the clinical uses, some infographics, and also a sort of repository of international guidelines, including albumin use, and the links to other documents related to albumin use in medicine. The second step is to provide a venue for online educational events like webinars, roundtables, and also Ask the Expert section, some interactive events that want to spread the knowledge of albumin worldwide. And also the possibility for users to directly communicate with the main content creators to ask explanation or suggestions. So let's see how we decided to build this platform. It is available from today, the albuminlearningnetwork.org, and we can see the homepage of the platform. Welcome to the Albumin Learning Network. And I tried to show a short video on the functionality of the platform. This is the homepage. And scrolling down, you can see the contents, the topics that we decided to include. Some of them are free for all users, and some others are restricted to registered users, and we will see what this means. And we can see the resources section, in which we included guidelines on albumin use and some other documents. There is the Meet the Expert section, in which for now are included me and Salvatore, the two main content authors. You can see the short biography, but if you are not a registered user, you cannot directly contact the expert to get in touch. And this section will be also populated over time by other experts that will join the project and will contribute to it. The registration is free and is easy and fast. You can create an account. And when you are a registered user, you can log into the platform. I am already a registered user. And at this point, you can access for free all the content of the platform. You can enter in one of the topic. You can see the video with voiceover, and also you can click the email the expert section. You will be redirected to this page, and at this point you can see an email that will be directly redirected to our personal email to get in touch and to have a discussion and questions and so on. This is the platform so far, and the part that is still lacking is the interactive part of the platform that will be built in the months to come to provide also webinars and live events to include other experts in this project. And the who. Beyond the content authors, we have to thank Sonia for his role in coordinating the project, all the members of the ALN task force that are your colleagues that help in reviewing the content and support in developing the platform, and also Nucleus for the technical realization of the website. Me and my friend and colleague Salvatore are the main content authors for now. And the when. Are you ready? Welcome to the Albumin Learning Network.
Thank you for that, Dr. Zaccherini. We really appreciate it. And so Dr. Zaccherini and Dr. Piano are our two experts who developed all of the content on the Albumin Learning Network. And then, of course, Dr. Caraceni was consulting, and he was a great contributor. And thank you, Dr. Maiwall, for your talk today. It's really exciting to have all these hepatologists here. I know that in the audience, we also have a few hepatologists. Some of you are not directly in the field, but keep in mind, I am told that the hepatologists are really good, the community is really good at Twitter. So if you have the chance, maybe during the break, go onto Twitter, find the PPTA Twitter site, and you can like our network and share it with all of your colleagues so that we get more interest and people join and become a registered user. So now, and also I'd like to thank all of the PPTA staff, both past and present, for all their contributions to this, and the PPTA Albumin Task Force, which is composed of PPTA members who helped to build this project. It really was a long work in progress, and we're really excited to launch it today. So I'm going to turn it back to Dr. Piano, who's going to moderate a question and answer period.
So now the discussion is open. If there are questions from the audience to the speakers. Okay, so perhaps I will start with a question for Paolo. Paolo, you highlighted that the non-oncotic properties of albumin, but we also heard that albumin in cirrhosis has some structural damage. Therefore, I'm wondering if there is a way to try, to have the effective albumin concentration. This is really something, a hot topic in the field, probably still an unmet needs. So what is your opinion about that?
Yes, Salvatore, can you hear me? Yeah, I think so. Well, there's no doubt that in all the chronic and acute inflammatory diseases, including cirrhosis, we have a damage of the molecule. And likely this damage is in increasing over time and with the severity of the inflammation, and is probably associated with the at least partial loss of function. Then cirrhosis is really a peculiar setting because it's not only a question of damage to albumin, but also we have a very low albumin level for several reasons. The most important is the reduced synthesis by the hepatocytes due to cirrhosis. So one of the goals will be to correct the damage and increase the functional part of the molecule. And this is something that happens when you infuse the commercial vials of albumin, but there are several studies also showing that in the commercial vials we have also an accumulation of structural damages. So we can say that the albumin is good, but is not as good as in young adult individuals. So an unmet need is to improve the commercial albumin, trying to increase the functional part of the molecule, which is the native, the part of the molecules with the native structures, with the lower degrees of damage. And it's an unmet need. People are working on that, and I think we have to wait for the future.
Thank you, Paolo. Any question from the audience? So I go on. I have a question for Rakhi. Rakhi, you showed that albumin may help patients with acute and chronic liver failure, but you also showed that in acute setting we should manage albumin really carefully because of the risk of circulatory overload. And this issue about the acute administration was also raised by other trials in the field. Therefore, do you have some advice or suggestion to use albumin and to monitor albumin use in the acute setting?
Yeah. So this is a very important perspective when we are using albumin. So whatever data, all of us have it in our personal experiences, that long-term, that is in the outpatient setting. It works wonderfully. It improves all the complications. You're able to meet your targets in these patients by giving high dosages. But at the same time, when you're using this drug in the setting of a patient who's already in the hospitalized, and that's what the entire study had also shown. So where they were targeting serum albumin in the hospitalized set of patients, so they found problems and challenges, and it was not able to show the benefits that we see in outpatients. So for inpatients, I feel we need carefully design studies looking at individualized protocols, because each patient in the setting of, we see a lot of factors. Once the patient is admitted, it is not just the severity, but once the patient is infected, it is the host, how the host deals with the infection. So the host factors have not been studied. And when we are giving albumin to everybody on the same dosages in the inpatient setting, that is why we're actually, maybe we are missing something. We are missing the background cardiac dysfunction. We're missing something in these patients, the capillary leak, the way the patients will get the leakage of the albumin with usage. So those things, I think, so we should have better biomarkers and better set of assessment and individualized protocols which could be helpful.
Can I make a comment on that? That's perfectly agree with Rakhi. It's perfect. A few days ago, I was in a meeting of intensivists, and so we were talking about the overload and the pulmonary edema with albumin, and you know, albumin is a plasma expander. And so, in this intensivist that is actually very famous, there was Jean-Louis Vincent from Brussels, said, well, that's not a problem of albumin or of any other plasma expander. It's a problem of the doctor. I mean, that's because you have to personalize. And so if you get a volume overload and a pulmonary edema, it's just because you expand too much. So we have never to forget that albumin is a very effective plasma expander. So I perfectly agree with you.
Yeah, probably we should move from a protocolized treatment that is a standard dose to a more personalized treatment, and probably in the next future we will have new data.
For the severe impatients,
yeah.
for sure.
Paolo, I have also a question for you, because we worked on a study of real life use of albumin. Therefore, some of issues that have been raised when we talk with experts in the field, with the pathologists, is about the logistics of albumin use. Therefore, can you give us some suggestion about how we are performing in Italy? What are the results of real life, the adherence of patients?
Well, Italy is really unique in that. I mean, we have a very long, and I mean about 20 years experience with the long-term infusion. Of course, after the publication of the ANSWER trial, long-term was even more diffuse among hepatological centers. We have a very similar logistics also. Actually, many patients receive albumin in the outpatient clinic. They just come, get the IV line, get the 4-6 vials of albumin and go away. It's question 1 hour in total and 1 chair. You need an infusion chair, a nurse, and 1 hour time. No more really. So with an infusion chair, you can do 5, 6, 7 patients in a shift. In a nurse shift, so it's really not very difficult. We have also territorial services, so maybe these patients are close to their homes, their houses, so it will be easier for them. And also sometimes, and I know that in Padua you have a very effective system. After the first 1-2 doses, we can infuse albumin at home. So, but it's a problem of healthcare system. I know that when I discuss about that with the colleagues from UK, they are, say, oh, we can't do that. I mean, it's really, I think, depend on the logistics of your healthcare. But the logistics is not so dramatic. I mean, there are many other things in medicine, other disciplines, much more complicated. And about the adherence of patients, that's incredible. Even in our real-world real answer study, was about more than 5 Italian centers, 300 patients. The dropout were less than 5%. So this patient just come. I mean, that's surprised me, but this is what we live and we see every day. And again, it's peculiar from Italy, because when I talk with other people from other countries, they say, well, they just stopped, and I don't know why. They just feel to be better, and they just come to receive the infusion.
It should be albumin given forever, or we can stop it because patient is improving? No,
I try almost always to stop albumin. That's what it has been shown in this retrospective study. This real-world experience. Of course, the stopping rule cannot be derived from the trials, from the randomized clinical trials. And about 25% of patients stopped albumin for clinical improvement. They resolve their ascites, and most of them also do not need albumin for a long time after. And the median length of treatment for these patients was about 9 months. So when we have a response, and the response for us is the resolution of ascites, we always try to stop albumin.
Can I also ask a question? So my question to you as experts is, when you're treating these patients, supposing not very uncomplicated, but a complicated ascites patient with albumin, so you identify 2 sets of patients, like you showed in ANSWER trial. The one is who rapidly respond, they come back, they improve their ascites, they have resolution. The other is the non-responders, who still remain persistently development of, they do get better, but they do not achieve the hard endpoints of resolution, reintroduction of diuretics. So what do you suggest for that set of patients, and why this is happening, that one set of patients is improving, the other is not?
I think we can both answer,
Yeah.
or Giacomo can.
Yeah.
Giacomo is following a lot
Yeah.
of these patients. Personally, the step is that if they do not respond to albumin or they require albumin, if we can put tips, we go for tips whenever possible.
Okay.
After albumin, we go for tips. That is a stent within the liver resolving portal hypertension. That is an invasive procedure, but is very effective. So that's the point. That's the first possibility. Second thing is transplantation, if they are listed for transplantation. We have some patients that they cannot receive tips, they cannot be transplanted, and they are not many, but these patients we keep with albumin until more or less death.
Okay. So I would just like to share our own experience in our country, because when you see refractory ascites, the outcomes of tips are not very good. So, and we see a lot of sarcopenia in our country, it's malnutrition and all that.
Yeah.
So we have some very good data. We have also done multicentric trials. We are showing that the combination of albumin we use an oral vasoconstrictor, midodrine. So it has synergistic effects in improving the hemodynamics. The albumin corrects the effective hypoalbuminemia and the effective hypovolemia. So we're seeing some very encouraging results. We'll be presenting a poster in the easel on the RCT that we completed at our center. And we found that when we're giving albumin at the dose as defined by the ANSWER study versus adding midodrine, we found that the benefits were more rapid in refractory ascites, not the uncomplicated, the refractory ascites group.
Okay, thank you, Rakhi. I think that time is up. It's time to close the meeting.
Yeah.
So I want to thank you very much for attending. And I guess now we have a break.
Thanks.
Thank you.
Thank you, everybody.